there were questions earlier about reimbursement. And we think in the practice organization, in Legal and Reg, we think that one of the potential solutions to this is to change the bargaining power. You know, most of you guys are small and solo practitioners, and you're dealing with a giant insurance company, and you've got no bargaining power. A lot of people know what an IPA is. Less people know what a management services organization is. But both of these are things that allow a bunch of independent practitioners to come together in a collaboration which does a number of things, but one of the things that people are most interested in is the ability to do joint negotiations. It'd be nice if you could just say, everybody in this room, we're all calling ourselves an IPA and we're now gonna do a big joint negotiation, and suddenly we have a lot more bargaining power. Unfortunately, it's not quite that easy, but we're gonna go through some of the things about it. And I can do my talk fast because we have resources, we have articles on this, so you don't have to take notes, and we're going to provide these PowerPoints, and at the end, the last slide talks about some of the resources that explain this. So I'll talk through it fast, and then you'll be able to look at it, and you can always call us if you have further questions. How many people just have a general sense of why antitrust would be an issue if you had a collaboration of you guys come together as an IPA? Just by show of hands. Okay, good, good. All right, so the reason antitrust is an issue is because under antitrust law, originally designed to keep the giant oil companies or the giant railroad companies from having a monopoly, they apply equally to you guys as small and solo practitioners. And one of the basic rules of antitrust is that competitors can't jointly negotiate, because to do that, they have to agree on price, which is price fixing. So you have two basic options to stay out of antitrust trouble. One is the messenger model, that's the older thing. The other is clinical or financial integration. Most psychologists we talk to are more interested in clinical integration, so we're going to talk about that more. But first, the messenger model. We haven't talked about this much in the past because one of our outside antitrust experts said, I don't even use that term anymore because so many people get into trouble with the messenger model. But I've talked to one practice we're keeping them below the radar. I've talked to one practice that's been doing this with an IPA for over 2 decades. So it's something that can work, and so we want to tell you about it. With the messenger model, you're basically serving as a conduit for price information between the payor and your network of providers. So say everybody in this room just decided to form, at least all of you psychologists, decided to form an IPA. And say I'm the person who's in charge of messengering. So I would say, everybody here, write down how much, and we'll make it simple. Let's say we're focusing on the fee for 90834. Everybody write down how much you're willing to accept for that, and I'm going to take the information, and then I go to insurance company A and I say, if you pay us $100, I can bring you a network of 200 providers. And so the insurance company, you think it'll be that easy. The insurance company says, well, how about 90? And you can just look at your chart and you can say, oh, okay, well, if you're going to pay 90, I can bring you 150 of these people. And you could also go to some of the people who did say they go that low. You could say, hey, you know, they're only paying 90. How many want to get on board for that? And this is how the messenger model works. The problem and the danger with it is that you really can't negotiate. You are a passive conduit for information going back and forth. And the people who are likely to do this have that entrepreneurial bent, you know, like some of the people we're going to hear from this afternoon. And it's hard not to slide into that, well, really? You're only going to take 90? And really, you know, this is the value, and you start, you know, that's how people get into trouble. They start sliding into negotiations. Let me talk now about the newer model. The antitrust enforcement agencies recognize that in the changing healthcare world, there are all these new entities like MSOs and IPAs. And it actually provides benefits to have larger groups that can do more, that can integrate and do all these things. And in order to be viable, they're going to need to jointly negotiate. And so they've come out with guidance on how you do that. And so this is the model that we talk about most. A properly integrated joint venture of it's an IPA or an MSO, promotes cost effectiveness, lower prices for consumers, improve quality, and that's the basic thing that the antitrust agencies would be looking at. So let me also just talk briefly about financial integration so you understand that alternative. And that is, it's substantial sharing of financial risk. For example, capitated rate arrangements with health insurers or risk pools that withhold a substantial portion of the reimbursement until certain cost containment goals are met. Most psychologists don't like those options. The advantage of clinical integration is it's all about what we've talked about earlier. It's all about improving patient care, making patient care more cost efficient. So you're doing things you ought to be doing anyway, and at the same time you're meeting the antitrust rules. So the key is it just looks just like the triple aim. The key to successful clinical integration program is that it yields lower cost, higher quality, more efficient delivery of healthcare. Most of the clinical integration models that have been positively reviewed by the Federal Trade Commission, the FTC, have most or all of these 11 elements. You don't need to take careful notes because we have an article that describes all this. It's provided in the resources at the end of this. One thing I say when I say positively reviewed, that sounds like lawyer speak, but the FTC doesn't give you a stamp of approval. They don't say, oh, okay, this model sounds great. You're good. Their position is, it sounds great, but we're going to see how it actually works out. And if this turns out to have bad anti-competitive effects, we may look at it more. But it's always a good start to see if you have a model that works well. If you're really setting one of these things up, we recommend that you get competent antitrust counsel to look at it. The whole lawyer portion at the end of this program is, do not try this at home, but we want you to be aware of the issues. Proper mindset is, don't ask, what's the bare minimum we need to do to pass the antitrust rules? That's starting you off on the wrong foot. The better approach is, how can we use integration to improve patient care? If you're starting that way, you're getting into the right groove on this, and that will make everything work better. I mean, basically, the idea is that you have combined goals for how you're going to improve patient care, and you have main ways of meeting them, and you're picking people who are going to be able to get you to that. And one of the things that makes these a little unpopular is that you have to have the ability to kick people out of the sandbox or warn them that they're going to have to leave the sandbox if they're not playing well with others, they're not helping to meet these goals. And one of the other aspects is meeting these goals has to be such a pain in the butt that people wouldn't do this if they didn't have the benefits of joint negotiation. That's one of the odd characteristics that the FTC looks for, but it makes sense. I mean, these aren't easy to do. They help your patients. They are a great selling point with payers, but these aren't the kind of things you can just do overnight. So I'm going to talk, one of the things we would hope that we actually get some of our people, and we have some people who we think might start worrying about this, we would hope we'd get our people to the point that they worry about having so much market power that they have to worry about whether they have so much market power that they're going to have to worry about whether their contract should have to be non-exclusive, which means that the people you sign up could actually make their own deals with the insurance company. Normally what happens is, if you have a big group negotiating, you're going to get a better rate anyway. So I consider that to be somewhat irrelevant. I suppose some people might be able to say, I'm so special that I could do better on my own, but that's rather rare. This is one of the funny things is the joint venture can't have so much market power that it can force pay increases on payers. But the flip side of that is that you can charge higher prices if you're providing a better product. And if you're doing all these things, you should be providing more integrated, better, more cost-efficient care. So I'm going to talk quickly in my remaining minutes about how these two models compare. Messenger model is easier to set up. You don't have to have all the resources to set up a clinical integration model. You don't have to worry about the 11 elements. It's easier for the members because they don't have to comply with all the clinical integration aspects, and they can also just decide, okay, so you got this deal with company A, I like that, I'll take that. But I didn't like the deal you got with company B. I don't want to pay, I don't want to be getting $85 for that, so I'm not going to do that part of it. One of the main dangers, though, is it's difficult to implement. It, it requires a lot of that back and forth. Well, what about this price? How many people do we get for that price? And as I said before, one of the main things is that people get into trouble with this because it's very hard. It's counterintuitive to just be a passive messenger. So these are the ways that the clinical integration model is better. As I mentioned, if you're doing these things, you're not just complying with antitrust rules, you're also improving your patient care, you're improving your cost efficiency. These things should make your services more marketable. So it's not just that you're staying out of antitrust trouble, but then you can also go to the payer or to the hospital system and say, hey, we've got this great clinical integration program. These are the things that we're finding with it. If you're doing the data mining that Vince was talking about earlier, you can say, our data is showing that by applying this, we're getting these kind of results with our patients. And that should be a selling point for you.